Mitchell, Mitchell, we need to have an EKG lecture that's really basic for psychiatrists. So that's the name of this lecture. Um, it's really meant for like new second years or second years that are going to be in EPS and have some undifferentiated patients or patients that come over from the ED that um, need EKGs, or you or mention that they're having chest pain in EPS and you get handed an EKG. Um, Most medical schools do a pretty cursory job of going over EKGs. So I'm just going to start from the basics so that we're all on the same page and go into some little bit more complicated things and things that are going to be worthwhile for you guys to like review and remember. And then the end is just a little bit of board review stuff for those that haven't taken step 3 yet. So um, we'll start out with what the boxes mean. Like I said, very basic stuff. So each EKG is about a 10-second tracing. And you'll notice that there's little boxes in each EKG tracing. One small box is 1 millimeter, which is important when we're going to talk about heart attacks, STEMIs. Uh, one small box is 1 millimeter and 40 milliseconds. 5 small boxes is one large box, which ends up being like 200 milliseconds. And then 5 large boxes is 1 second, and then 300 large squares is 1 minute. So kind of just breaks down each one for you here. So like one small box, 0.04 seconds, one large box, 0.2. So it's easy to see. So each EKG tracing has its own tracings and own intervals and segments and stuff, and they're broken down here. So from the far left, this is the P wave here, indicates atrial depolarization, and the interval that starts from the start of the P wave, the start of the QRS complex here. This is the QRS complex. So the Q wave is the first negative deflection down there. Not all leads will have a Q wave. And then the next one's the R wave, which is the positive deflection that indicates ventricular depolarization. And then the S wave is another negative. It's the second negative deflection. The J point right here is the point where the QRS complex and the like the T segment meet. Then the QT interval is probably the most worrisome thing for you guys. That's over here. That's the start of the Q RS complex of the Q to the end of the T interval. So that displays that out for you guys, what that is. Another important thing is the QRS duration here. So that's how wide the QRS complex is. Sometimes when people get tachycardias, we'll describe them as wide complex tachycardias, and you'll see that that's from the start of the Q here to the end of the S here. And then another big one is the ST segment. So like as in like ST segment elevation myocardial infarction. That's about the J point here. So you're supposed to go from where the end of the P wave kind of enters in the QRS complex to about the J point, which is where the S and the T meet. And then this is the segment here that we're worried about. Like, is it elevated from the baseline, which is over here? Is it depressed, et cetera, et cetera? We'll go over that in further slides. So when Sabina and I were learning how to read EKGs in medical school, she would frequently say the squiggles don't really make any sense. They just look like squiggles on a tracing, which is the reason for the title of the slide. So what do the squiggles mean? Like I mentioned kind of in the last slide, so each tracing starts with a P wave. So that's the positive deflection, and that represents atrial depolarization. And then we get into the Q wave, which like I said, is the first negative deflection in the QRS complex. Not all leads have them. Sometimes in like board questions, they'll use the Q wave to describe somebody that had a previous MI, because Q waves tend to pop up when that happens, but not all Q waves are bad. For example, Q waves have to be like one small box deep and one small box wide for it to be abnormal and to be concerning for like a previous MI. So you'll frequently see leads that have very small Q waves. And then the next one is the R wave. So that's the positive deflection. This represents ventricular depolarization of the heart. The S complex is the second negative deflection there. And then we get into the T wave, which is the repolarization of the ventricles, and it's usually the positive deflection after the QRS complexes. Sometimes T waves can be inverted, and that can be normal, especially in leads AVR, which we'll see in upcoming EKGs. But normally they're supposed to be upright. And then sometimes you can have a U wave over here too. I didn't mention this in the last slide. This is frequently seen in patients with low potassium hypokalemia. It's just an extra hump there. By the way, if anybody has any questions at any point, just let me know. I'm just gonna keep going through this. If nobody has any questions, this should all be pretty good review for you guys. How long should the squiggles be apart? So each interval has its normal range, and when they're outside of the normal range, that can cause issues and different pathologies. So, for example, the PR interval from the start of the P wave to the start of the QRS complex from here to here, that should usually be less than 200 milliseconds, which is 3 to 5 small squares. If you get longer than that, some of you may remember that is like when we get like first degree AV block, second degree AV block, Wanky block. When it gets shorter than that, that is concerning for things like WPW, like that have like a short PR interval and then like a delta wave. It is just like a abnormality in the atrial depolarization, like the P wave is indicating. QRS complex should be less than 100 milliseconds, which is about 2.5 small squares. If you're usually there's no issues if it's like, narrower than less than 100 milliseconds. But if it's more wide than 100 milliseconds, that's when you get into concerns about like, is this like a ventricular tachycardia, or is it just something simple like a bundle branch block? It's just usually just indicates delays in the transmission from the atria to the ventricles when it causes depolarization. That's why things get wide. And then, like I said, the thing that you guys probably care about the most when it comes to EKGs is the QT interval. So I'll go over that one more time. So that is from the Q wave here to the end of the T wave, the very end. So in men, this should be, if it's going to be prolonged, it's going to be greater than 440 milliseconds. And then in women, it's 460 milliseconds. That's the technical definition. If you ask any cardiologist, they get impressed with a long QT interval if it's over like 500 milliseconds. And if it's anything less than that, they're not very impressed at all. We'll go into the QT interval just a little bit more here. So you guys will notice that when you get handed an EKG, it's got like a computer interpretation of it on top. It'll tell you what it thinks the rhythm is, what any abnormalities it might be. It may be saying that, oh man, this looks like it's a STEMI on the top. But in the top left corner of every EKG printout has all the intervals of every tracing. So it'll have the QRS interval, it'll have the PR interval, and it'll have the QT interval. I assume you guys frequently look at that QT number, and then kind of that directs your medical decision making on whether or not you can use a specific medicine or not for patients on consult or an EPS, et cetera. I would say take that QT number on the EKG printout with a grain of salt. Again, it's a computer that's calculating it. It may not get the perfect number. If I'm looking at a QT interval on there and it's the EKG printout is saying it's wide, but I don't really think it's wide, I tend to just calculate it myself, which is exactly what we would do in our cardiology rotation too. What I would do is also, by the way, so there's the QT and then there's the QTC. So the QTC is what it estimates the QT interval at a normal heart rate of 60 beats per minute, which is what you should be using because the QT interval shortens at faster heart rates and it lengthens at slower heart rates. So it's a dynamic thing. The QTC is just telling you what the QT interval would be if it was a normal heart rate. So if I wanted to calculate, I frequently calculate my own QTC interval if I'm suspicious that the EKG printout is wrong. So as for many things, there's a calculator for this on MD Calc that I use. And this is like a screenshot of what it looks like. So you always want your paper speed to be 25, by the way, so that's standardized. And then you could put the heart rate in there. And then you could choose any one of these formulas. I just keep it on the top one. But the important thing is you have to type in how many small boxes between the QRS complex and the end of the T wave, like I showed here. So from here, it'd be 1, 2, 3, 4, 5, 6, 7, 8, 9, like about 9 or 10 boxes there. And frequently you'll find that the QTC is actually shorter than what the printout is saying. That can be pretty helpful, especially if you have somebody that's super agitated that you'd like to give a specific antipsychotic and EPS, but you feel like you can't because the EKG is saying it's prolonged. And if you don't have time and don't have time to like pop it into the MD Calc and you're super concerned and you need to make a decision right now, what we typically do as ER doctors and what cardiologists do too is that we just look at the R to R intervals, and as long as the QT is less than half the R to R interval, it's probably not prolonged. So what I mean by that is the R to R interval here is the R's of each QRS complex, and if right here looks like the middle between the two. As long as the end of the T wave complex is before this, it's probably not prolonged. So you can see that this would be like not a prolonged QT because the T wave complex ends way over here in the middles here. Does that make sense? Cool. It's one thing to know that an interval is prolonged, like the QT, but it's also nice to know what the causes of those things are. So I have them listed here for you too. So it's not just medications that cause it, it's also frequently low electrolytes, hypokalemia, hypomagnesemia, hypocalcemia, hypothermia can cause it, and then a lot of antibiotics. Methadone is a classic one that you'll get on the board exam for a prolonged QT syndrome. Zofran can cause it or prolong it. And then, of course, your beloved antipsychotics, antidepressants, and antihistamines. Um, so another important thing to know is how to calculate the rate on an EKG machine. Again, you can just look at uh, the computer readout at the top of the EKG, but it's frequently not correct because, for example, a lot of people have like atrial fibrillation and the computer is counting everything to be regular, but it's not. So counting your own rate on your EKG can be helpful. There's a couple methods to do this. So especially when the rate is regular, you can we use what we call the large square method. So you can divide 300 by the number of large squares between each interval. So here's an R to R interval here. There's one large box between here. So you can divide, there's two large boxes between here. So you would just divide 300 divided by 2, and you would get 150 beats per minute. And you can just keep marching that down. So it's 300, 150, 100, 75, 60, 50, 38. You can just go down the line. If you just remember that calculation, you can figure out what the beats per minute are between each R-to-R interval, and that's helpful. If the rate is not regular, like for example, if somebody is in atrial fibrillation, you can use a different calculation. You can remember that each printout of the EKG is about 10 seconds long. So what you can do is you can calculate how many R waves there are in each printout, like on a lead, like take V1, for example, and calculate how many there are on the strip, and then multiply that by 6 because each strip is 10 seconds long. If you multiply that by 6, that's 1 minute. So you can get a heart rate that way. And again, that's super useful for irregular rhythms because the computer printout is assuming that it's all regular. And in atrial fibrillation, the beats are occurring at different times. So that's helpful. Important place to start on when looking at EKGs too is realizing what's normal. So What is normal is called normal sinus rhythm. It's a rate of 60 to 100 beats per minute. Slower than that would be sinus bradycardia. Higher than that would be sinus tachycardia. But normal sinus rhythm is right between 60 and 100 beats per minute. So each QRX complex is preceded by a P wave. So you have your P wave here. You can see there may be a little bit of a Q wave here, but probably not. R wave, S wave, and then the T wave. So less to know about this, but a normal P wave, just so you guys know, for normal sinus rhythm is usually upright and leads 1 to 2 and inverted in AVR. And the PR interval is constant. Like I said before, if a PR interval is lengthened, that's when you get into like the AV blocks, like first degree AV block, second degree, third degree. And if it gets short, that's when you get into other arrhythmias like WPW. But it's normal sinus rhythm if it's constant. And then QRS complexes are generally less than 100 milliseconds, that 2.5 boxes. So this is a good example of a strip of normal sinus rhythm. And you can tell that the R to R intervals are exactly the same distance apart, which won't be the case in other rhythms. So the scariest thing that you could probably be handed on an EKG is that, oh my gosh, are they having a STEMI? And this wall of text to the left is the technical definition of STEMI. It's helpful to know. It's kind of hard to remember, but you can just remember it by that you got to have at least like 2 millimeters of elevation. So as we talked about before, here is the baseline. If you guys can you guys see my mouse? Sabina, can you guys see my
Yes.
mouse moving?
Yeah.
Okay, cool.
Yeah, we can.
All right. So the baseline is here, like where the P wave comes in. And then this is your like ST segment up here. This is like remember the S wave, which is a positive deflection, and then the start of the T wave. So if your baseline is here, this is at 1 small box, 2 small box. That's 2 millimeters of elevation there. Same thing here, right? Like here is the baseline down here where the P wave is, and then your ST segment's way up here. So that's like what, like 7 or 8 small boxes elevated. So that is what we're talking about when we say this is an ST segment elevation, which many times means that it's a heart attack. So the formal definition is you got to have a clinical symptoms consistent with acute coronary syndrome. That's like chest pressure radiating to your arm, to your jaw, dyspnea with exertion, consistent with previous MIs, et cetera, et cetera. And you got to have it in two leads that are next to each other. So V1, V2, V3, V4, leads 2 and 3. You can't just have one lead that has an elevation. That doesn't count, and it doesn't make anatomical sense in the heart. So if you're a man under 40, it's usually 2.5 millimeters of elevation. In leads V2 to V3 is the technical definition. And then if you are over 40, the criteria lowers a little bit. So it's just 2 millimeters. So it's 2 small boxes that it has to be elevated. And then for women, it's only 1.5 millimeters of elevation that meets the criteria. So lesser. And then why leads V2 and V3 are important. It's because they're the precordial leads. It's the leads that correspond with the LAD vessel. And sometimes, as I'll show in further slides, there is a little bit of elevation in those leads at baseline, just because of differences in electrical transmission, et cetera, et cetera. And the criteria for that is it has to be higher elevation than it is in the other leads. So leads that are not V2, like usually V1 through V3, just have to be 1 millimeter of elevation in contiguous leads. So again, I'll go over it one more time. So like what you want to do is you want to look at the baseline from the P wave here and then count up to the ST elevation. So this is 2 millimeters of ST elevation. The baseline is here. This is at least 2.5 meters of ST elevation. So that's what we're looking for.
So you just measure at the start of it, right? Not like at the peak of it. Like
Yeah,
right
I
where
mean you measure from like you count up. Is that what you mean?
just directly up. Okay, yeah,
Yeah,
yeah.
yeah. And then here is the classic EKG printout for the different anatomy and what the leads represent. So leads V1 through V4 are the anterior septal. So that's the front part of the heart that's served by the LAD, the left anterior descending, which is the biggest vessel in the heart, called the widowmaker. That one, if you have an MI. Over here, leads 2, 3, and AVF, or the inferior leads. Technically, they're served mostly by the right coronary artery and sometimes the left circumflex. The lateral leads are leads 1, AVL, V5, and V6. So that's the left circumflex vessel of the heart. These are all the anatomical regions of the heart. So if you have elevation in lead 2, you would expect to have elevation in lead 3 and AVF as well, because they're all being served by the same vessel. So sometimes, like I said, you can have elevation, but you're not sure if it's a actual STEMI or not. What a lot of people don't know is that if you're going to have a STEMI, there's usually what we call reciprocal ST changes in the opposite leads. So reciprocal meaning like the leads that are opposite from them. The heart is so the EKG machine is taking tracings of the heart based on vectors, which I'm not going to go into because it's super complicated, but the leads all correspond to different vectors and different angles of the heart, and they're all catching the heart at a specific vector and angle. And each lead has an opposite lead. So like if one lead is catching it at 90 degrees, there's another lead that's catching it like at 180 degrees, for example. And if you can picture, if you have elevation in one lead, if you're looking at the mirror image of another lead that's opposite of that, it's going to be depressed, which is the opposite of an elevation. So frequently, if people have ST elevations and it's concerning for a heart attack and poor blood flow to a specific part of the heart, you're going to have reciprocal depressions, which is also indicating poor blood flow to the opposite vector. So in this example, you could see that you're taking the baseline from the P wave here, and you're going to go up, 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 up. It's like, I don't know, like 5 small boxes, 5 millimeters of ST elevation. And then you go over, this is in lead 3, so lead AVL. You'll go over and you'll see that these are what we call ST depressions. So you take your baseline from here, down, 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 and your ST segment is depressed, and you got a little bit of a T wave inversion there. That's super concerning for a heart attack. A mnemonic that we use to help to remember which leads to look at for reciprocal change is called PALES. And I have it listed here on the right. So for example, if you have ST elevation in the anterior leads, which is leads V1 through V4, then we would look at the inferior leads because that's the reciprocal, like opposite mirrored lead that you would expect there to be also ischemia in. So if you have ST elevations in the anterior leads here, you'd expect to see ST depressions or at least T wave inversions in the inferior leads, leads 2, 3, and AVF. Same thing if you saw ST elevations in the inferior leads here, leads 2, 3, and AVF, you would expect to see reciprocal changes, T wave inversions, ST depressions in the lateral leads, which is leads 1, V5, V6, and AVL. So ST elevations here, you would expect to see depressions over here. The mnemonic is called PALES. It's super helpful if you can remember that. So here's an example of an EKG that is a STEMI. So we can see here, especially like leads V2 and V3, V4, they look pretty elevated, right? So here's the baseline that we're looking at, the P wave, and then we go 1, 2, 3, 4, 5. Like there's like 5 elevations here. And we're like, oh, that doesn't look very good, but I'm not sure. We can look over to remember our PALES mnemonic. So A, then look at I, which is the inferior leads. We can look over here and see, okay, here's our baseline, and this looks kind of depressed over here. We get some T wave inversions, and there's your reciprocal change. So that's how that works. Make sense? Now, what about this one? This one trips people up pretty consistently. I've had some EPS residents walk over and hand an EKG to me that looks similar to this, and I've had people that text me at 3 a.m. while they're moonlighting, for example, that live in my house that want me to look at EKGs that look like this. And so, for example, if you look in the anterior leads, you're like, oh, this is kind of elevated here. This is, I don't know if this is actually two boxes or not. This kind of looks like a smiley face elevation here. And there's like a little bit of a notch here on some of them. It looks like a smiley face elevation. Is this a heart attack or not? You'll notice that there's no reciprocal depressions anywhere else. There's T-wave inversions here, but that's normal in AVR. What is this? This is actually what we call benign early repolarization. So this is very, very common. You'll see this on many EKGs. It's most common in your like younger, middle-aged African American males. It is a benign ST elevation in the anterior leads, and it's concave. So like a smiley face, like I said, and its most prominent leads V2 to V5. Sometimes you'll get the notching or the slurring at the J point, which is right here. And then you'll get some prominent T waves that are associated with it. And like I said, there's no reciprocal ST depressions to suggest heart attack at all. So if you want to look at it one more time, um, maybe a little bit of elevations here, but smiley face here. That's nice. You see some notching here, which is also like it. And this is most prominent in V2 to V5. You see some really peak T waves here, which is corresponds with that, but you don't see any ST elevation, or you don't see any ST depressions or T wave inversions that are concerning. And again, T waves are supposed to be inverted in AVR, so this is normal. Contrast that to this, which is ST elevations in the anterior leads, and then depressions like over here, some T-wave inversions. That's concerning. Another thing that you'll probably see at some point on your internal medicine rotations or an EPS is the too fast and irregularly irregular. So this is obviously atrial fibrillation. So this is an irregular rhythm. So what we mean by that is we look at the R waves here, and the distance between the R waves are all different. You can see these two are pretty close together, and these are much wider. There's no P waves. Like one could probably say like, oh, is this a P wave here? These are really just like fibrillations. There's no like distinct P wave that you could pick out here. Absence of an isoelectric baseline, which just means that there's like a lot of artifacts, is very like wavy here. And then this is the variable ventricular rate. So this would be a good one to count the number of R waves and then multiply by 6 to get your rate. And then the QRS complexes are usually narrow, less than 100 to 120. When we care about, so AFib is the most common arrhythmia in the world. And many people are on rate control, whether it be metoprolol or diltiazem or some other calcium channel blocker. They're on Eliquis to prevent stroke, et cetera, et cetera. When we care about, the only time we really care about atrial fibrillation is if it's new for somebody and it's causing them distress, like horrible chest pain, shortness of breath, diaphoresis, et cetera. And that's when we consider cardioverting them. Or if it's fast, which is what you're going to see most often. So that would be atrial fibrillation with rapid ventricular response. So AFib with RVR. That's technically when the heart rate is greater than 110. You will probably see this in EPS. I saw it. I did an EPS elective in May, and I saw this, and we had to send somebody over to the ER because you frequently get older people that have a lot of chronic medical conditions, and you'll notice if their pulse is pretty high when they take their vitals, but they're not complaining of anything because they have baseline AFib and don't feel it. But when we get concerned is if the heart rate is over 110, and then usually typically what happens is then we give people medicines to get the heart rate down to less than 110 because it decreases cardiac output, et cetera, et cetera. It's not healthy for the heart to be at a rate that high in atrial fibrillation for a long period of time. And then only other one that you might see that will be concerning is too fast and regular. So this is what we call supraventricular tachycardia, SVT. So the a helpful tip for you guys to know is like typically the max sinus rate that somebody will ever be is 220 minus their age. So if they're higher than that, so if you're like 60 years old, 220 minus your age will be 160. So if you're like doing like a really hard workout, you could be sinus tachycardia up until 160, but it's typically that would be typically pretty abnormal. So when you see heart rates, typically people in SVT are like 180s to 200s. So it's really, really high. And then they have normal QRS complexes, so less than 100 to 120 milliseconds. And then sometimes you'll see P waves, sometimes you won't. They can be before the QRS complexes, after, buried in it, etc. But the important thing here is that the R to R intervals are the same throughout compared to AFib, where the R to R intervals are changing constantly. So why do we care about SVT? It also can cause people to feel horrible, have chest pain, shortness of breath, cause them to be hypotensive because their cardiac output is poor. That's when we cardiovert them or give them adenosine, which I'm sure you guys have seen at some point, to help them out of that. And then my last slide here is more just like board review stuff for people that haven't taken step 3 yet, or just for anybody that wants a refresher. I'll just go over a lot of these. This is a pretty niche like board question. This is called ARVD. You can have the epsilon wave and V1 to V3, this like little notch here. And it has an associated T-wave inversion and QRS widening. If you can just recognize that, you'll get the question right on the board exam. Sodium channel blockade, so that's like classic like TCA overdose. So you'll get QRS widening and leads AVR and a T-wave inversion associated with that. You give these people sodium bicarb to help until they QRS narrows to an appropriate amount. Brugada is that classic like sodium channel blocker, sodium channel deficiency in people that are younger that have like sudden onset death or syncope, etc. You can think of it just as this like shark fin that they have, and usually the anterior leads, and they have a T-wave inversion. Hyperkalemia is a big one. You'll take care of some people on your medicine rotations that have end-stage renal disease and they miss several sessions of their dialysis. And the classic is that you get really uh, elevated peak T waves that some will say that you don't want to sit on. That's how you know that the T waves are peaked. But that's only the first sign. Everything gets basically, you can think about it as everything gets really wide in hyperkalemia. So all the intervals widen out, the QRS widens out to the point where you just like have like a sine wave, which you can just Google it. It's just like a very wide complex, and that's like when they're on the point of almost dying. That's when you give them calcium and insulin and dextrose, et cetera, all those things that you guys remember from board prep. Pericardial effusion looks like this. That's like so you know how these QRS complexes are big. They're normal size. These contrasted are much smaller. That's because we call this low voltage. That's because the EKG leads can't get to the heart because there's a big amount of fluid sitting on the heart. People have small QRS complexes when they're obese, when they have COPD because they have large lungs, when they have a pericardial effusion like this. And then the classic EKG finding is electrical alternans, which is like the QRS complexes are differing sizes and differing voltages as well. When you rotate through the ED and you see any number of geriatric people on blood thinners that roll through room 9 because they fell and hit their head, and you get an EKG on them and it looks like this, it means they probably have a big intracranial hemorrhage. You get your QT prolongs, you have a giant T-wave inversion. It looks scary. That can show up on board exams too. And then I was referring to WPW earlier here on this presentation. So this is the delta wave. They call it the slurred upstroke of the P wave going into the QRS complex, and then they have a short PR interval, so less than 120 milliseconds, which is about 3 small boxes. That's pretty classic for WPW. This EKG will probably show up on your board exam as somebody that a young person that's either tachycardic or passed out. They like to ask this question. And then hokum is also like a classic one they'll ask about. So that's like the dagger Q waves. So like I said before, like bad Q waves are at least one small box deep and one small box wide. This one meets that criteria. And these, so they call this dagger Q waves, and then they have left ventricular hypertrophy, which really just means that the QRS complex is really tall. It's not super important for you guys, but that's what that looks like. So this is just a little bit of board prep. And then one final thing that I want to add is that it's pretty scary being an EPS, especially at night by yourself. And if you're getting handed EKGs and you don't know what you're looking at, or if you're really on any service and you don't feel like you can ask the other co-residents that you're with or attendings or whatnot, the ED always has one attending on and multiple residents. Here's our picture from last year. Some of the obviously there's new interns and stuff that are on now, but we are more than happy to look at your EKG for you and answer questions, or if you just want to call us, more than happy to do that. We get inundated with hundreds of EKGs on every shift. We look at EKGs all the time. We're happy to help you guys out because you guys help us out with our psych patients. Happy to do that. And that is it. How'd I do?
Thank
Hey,
you.
Mitchell. I have a question. I had a patient once with presentation that was consistent with Wallen's syndrome. They had elevated V2 and V3, and they were complaining of intermittent cardiac symptoms like chest pain, numbness, tingling in the left-sided arm and neck. And they had a stent placed when they were very, very young. They couldn't tell me what the condition was, but they had, sorry, not a stent, but a valve. I think it was mitral valve placed when they were very young. I sent them to ED because the V2 and V3 were up. I didn't have a backup EKG, and I had no baseline, but the ED was able to find the old EKG and saw that it was the same, and they sent him back. This was at a moonlighting facility, not here. So
Yeah.
I'm trying to understand that what needs to change in the patient's presentation to know that, okay, now this warrants another cardiac workup, because those people probably would have chronic V2 and V3 elevation, correct?
Yeah, it's Welland, what you're describing Welland syndrome is T-wave and like T-wave inversions like this.
Right.
Right. Is this what you saw?
Yes.
Yeah. So for everybody that doesn't know what Welland syndrome is, it's a finding on EKG that's T-wave inversions like this. It is basically stenosis of your LAD. So it is kind of like a heart attack, but not yet. So what Nish is describing is that he saw some very scary looking T-wave inversions like this, which would make me nervous as well. And then he sent him to the ED. If I guess in theory, Nish, if your T-wave inversions were the same, that's one thing. And I guess that's why they sent him back. But in somebody that's also complaining of chest pain and having these symptoms and has had a history of coronary artery disease, that sounds like they warrant, a troponin and possibly an admission for cardiology evaluation. I'm not sure, obviously I wasn't there, but I would agree with your decision making on what you did. If I saw an EKG that looked like this and somebody had chest pain, you're almost borderline supposed to be talking to the interventional cardiologist because they need an urgent heart catheterization. I don't know if that answers your question, but I'm just trying to validate what you did.
Yeah, I was just wondering because that patient, I think sometimes he just says, so this was at KCPC, so sometimes he says things to go to ED and get out of the prison.
Yeah.
But I can never tell if the EKG is fine, if I repeat it, when should I send him? Because, he says he's having chest pain. So if they're like, objectively, if you can see the signs that, they're diaphoretic, they're grimacing because they're in pain because of the cardiac complaint, that would obviously warrant sending them to ED. I'm just wondering, like, should I do workup on my own before I sending them to ED, or should I just go ahead and send them because of their complicated history?
I would, it's hard with your KCPC patients. I think that,
Right.
history taking is difficult, et cetera. If you are, what I would have done is if you weren't super concerned, you were kind of thinking that the history was a little bit embellished, and you saw the EKG and you found an old and you saw that there was really no change in the EKG at all.
Mhm.
What you could do is a troponin. I would have just ordered a troponin and see if it was significantly elevated from the baseline, and then you have your answer. You just send them over the ED. But if it's negative, and you leave the guy alone for guy or gal alone for a while and kind of come back and do your like objective, exam. Like, are they actually looking pretty comfortable or are they actually in distress? Those kind of things.
And then Mitchell, there was a question in the chat about the benign early repole. Like, how is that different from pericarditis when you have like diffuse ST elevation?
Benign early repole is usually only ST elevations in the V2 through V5. Pericarditis. So I picked an example that showed ST elevations in a lot of the leads because it was a good example to show. But pericarditis shows, hold on. I get a lot of these. I got a lot of these pictures and stuff from a website called Life in the Fast Lane. You guys probably have heard of it before, but it's super helpful. Let me share my screen again. So this is pericarditis. This is So pericarditis is inflammation of the pericardium, which is the outer wall or like outer wall of the heart. Typically, people will have like a chest pain. It's worse when they lay down and better when they sit up. They'll have some shortness of breath with it. Usually it's after like a upper respiratory illness of some sort. Their troponins will typically be negative because it's only on the outer wall. And pericarditis goes through stages. So stage 1 is typically ST elevation and PR depressions. So here's your ST elevation here, and then your PR depressions. Benign early repole doesn't have PR depressions. And then stage 2, it'll be normal. And then you'll have some like inverted T waves in stage 3 or so. So if I can go back to my benign early repole. So I do agree. This kind of looks like there may be some PR. Maybe I just picked a bad example. But there's not really like ST elevation in some of these leads. Like this is like questionable. There's no ST elevation here. There may be some PR depression like here and here, but it's much more obvious. What I was just trying to show in benign early repole is that there's ST elevation in V2 through V5. That's how you differentiate it. I hope that helps.
Okay, yeah, that makes sense. Okay, guys, any other questions for Mitchell? All right, thank you so much. We really appreciate it.
You're
This was
welcome.
really